Okay, it's Dr. Buford. We're just getting started on the right shoulder. You're in what we call the lateral decubitus position, meaning you're laying on your side. Your left shoulder's down. The camera's coming in from behind on the right shoulder, and we're about to place a spinal needle into the joint. You can see the needle coming through right there. If you were standing up and we were just looking and had the camera in behind you, it would look like this, right? Because there's the socket and there's the ball coming off to the right. So this is what it would look like if you were standing up and down, straight up and down. But since we lay you on your side, it rotates like that. And it just gives us a little more room to work with to operate in this position. So with the spinal needle, we can actually get a sense of what's going on with this biceps tendon. This is our initial look. Looks like there's a little bit of fraying as we expected in the labrum. The tip of that needle is just a millimeter, so things are magnified 30 or 40 times on the screen. There's a couple diagnostic criteria we have for determining if this is truly a slap lesion that needs to be repaired. We can see the injury to the cartilage here. Okay, so this is really right at the margin. It's not a horrible detachment, but we also know that we've been trying for a year to get you better, give or take, and this is certainly enough in a thrower like you to be a chronic problem. There you can see that. Now, if I were just injecting something through this needle, we had the discussion of why not just do a PRP injection or even a bone marrow concentrate or microfat injection, and the reason is just injecting, first of all, to get the needle to this point consistently without looking right at it is impossible. Invariably the needle will hit the cartilage, and you can see how it doesn't take much to just drive that needle into the cartilage or into the biceps tendon anchor and cause further damage. You really need to be pinpoint right there, and there's no way to really see that the first time every time unless you're looking right at it with some type of scope. So that's number one. The number two problem with trying to do this with the injection is after we inject here, we haven't really solved the problem because we need this to heal back to the bone. And this is pulled away from what is here, just cartilage. So what you're going to see me do is take away all this cartilage here, and then we're going to reattach this soft tissue back to the bone. To just inject here, although it may stimulate a healing response, it's going to fail because we haven't done one of the basic orthopedic tenets, which is give this a place to heal, because this won't heal back to cartilage on its own. It'll heal back to bone, but no one's really been able to show that just debriding this area gets it to heal. In fact, that study's been done many, many years ago. We examined your shoulder before we started, and there was no instability. That was something else we talked about. So I don't think there's any significant instability. Here's the anterior labrum. And again, you can see it's not very big, 1 or 2 millimeters. Okay, and it's not a big margin of error. If you miss the labrum, you're going right into the cartilage, and that's not a great thing to do if you can avoid it. As we look up here, you can see the subscapularis tendon. This is the superior border of the subscap. And so we're coming through this triangular area called the rotator interval, which is where we typically do all of our work through cannulas in that part of the shoulder. As we look down here, we can see the labrum basically kind of falls off. This is the anterior band of the inferior glenohumeral ligament. It is just a fold in the capsule. It's not, again, not something that's really you can target. It's an intra-articular structure. The tip of this 18-gauge spinal needle is basically thicker than the ligament. It wouldn't take much just to go right through it. But I could, if I wanted to, put a needle right there and we could inject a little something there. But again, this is under direct visualization. As we look posterior and inferior, we can again see that you can't really inject labrum here. And as we look posterior, there's really not an injectable labral structure back here, and that's pretty common. Here's posterior capsule. That all looks good. So what is often read as a labral tear, for example, that little blip right there might be read on an MRI scan as a labral tear, but when you actually get in here and start looking at things, that's a little piece of loose cartilage. When you get in here and start looking at things, it's not really something that even really needs to be addressed. So what we're left with is so far just this biceps tendon anchor as we suspected. We use a loaded suture anchor to fix it. We'll show you that technique in a minute. The rotator cuff is going to be here to the left, and obviously in a thrower we want to make sure that this is okay. So here's the supraspinatus here. Some minimal undersurface fraying, that's fine. But what we're looking at here is the insertion into the humeral head, and that looks just great. So no signs of any significant problems with the rotator cuff. It looks like the one thing that we really suspected coming into the operating room which is this biceps tendon anchor. So we're going to go ahead and place 2 cannulas through the rotator interval, and we'll get to work doing that. Okay, so we've got our 2 cannulas coming in now through the rotator interval, the blue one on the left, kind of the clear one on the right. You can see we're to the left, which is superior to the subscapularis tendon, which is just to the right of that clear cannula, and the blue cannula is a little bit higher up in the interval. So we're going to take a shaver now, and this is what we can't do under fluoro or under ultrasound. We can't do this. We can't reach in with a shaver. Hold on, I'm going to reposition the shaver. Hold the camera right there. Okay, so with our shaver, this is another way that we tell if we have a true slap lesion or not. If this shaver just drops down, this is now a 4 millimeter diameter device. Remember that spinal needle is just a millimeter. And so if this just drops down, that's another indication that we've got excessive laxity here. And so this is just meeting that criteria for a slap lesion. But this is, hold the camera there, this is what we can't do without this surgery. We can't remove this cartilage that needs to be removed. And so we start right here. Let me show you how this spins. When we hit the button, this just spins like that, and that allows us to remove some cartilage. So we'll get to work doing that. Okay, so I just wanted to show you here, this is the part that I can't do in the office with a needle. You can see we're down to yellow. That's subchondral bone, meaning that's below the cartilage. We've removed the cartilage here. And that's what we have to do if we're really going to expect this tissue to heal. And so you can see how pinpoint and how precise we have to be as we just slowly do that. You know, any millimeter off to the right or to the left is into structures that we don't want to damage. And so especially in a young athlete like you are, which is typically the type of patient for which we're doing this isolated slap repair, we really need to be precise with our technique. And you know, it's a long-winded answer, but you asked some really good questions in our discussion in the office. So I think that's pretty good. We'll use our shaver just to remove any of the loose pieces. But now that we can see the bone, we know that we've removed enough cartilage, and that'll heal. And so now when I let go and we anchor this back down, that'll heal just like that because it's got a surface to heal to. And so that's really critical in this procedure. Take that. Okay, so here you can see what we've done here. We'll push in a little bit. You can see we've got the bone exposed. I'm going to run the shaver just a little bit more. Again, obviously we can't do this in the OR. I'm sorry, in the office. We wouldn't want a spinning, powered shaver any place where we couldn't see it directly. So we're going to chalk this up to one of those procedures that'll never be replaced as we currently understand it without being able to look right at it. So now we're ready to go ahead and start planning the repair. We'll show you how we do that. Okay, so there's a lot of ways to do this. All of them involve placing some sort of anchor in the bone. And that metal tube you see is a drill guide. And through that, we're just basically taking a wire and drilling a hole in the bone. Now we'll take the anchor. These anchors are made out of all suture material, so there's no metal or anything like that. And then we just tap these down into the bone. And that gives us 2 sutures to work with. So you can see how that works there. Now, with this sort of anchor, it's important to kind of load and tension the anchor initially to make sure it's seated. So I'm pulling on the sutures. When I pull on the sutures, look how strong that is. I'm moving your whole shoulder. See, I'm going to pull on the sutures right now and see how everything moves so that we know that that's solid. And so now the next part of the technique is going to be to use a crochet hook and take some of these sutures out of the way. We only really want to work with one suture at a time. Really important not to wrap these sutures around the biceps. You don't want to strangle it. You want to leave the normal motion that you have. Hold that right here. And so, again, the technique here is very important in how you do this. We'll go ahead and take these 3 sutures there. We're going to take a switching stick. Okay, now as we pull back, you can see how the wire is going to bring that suture with it. And then we'll pull tight. And now we have that suture underneath, see? And so now we'll get the partner suture, and that'll give us a loop. Crochet hook. Okay. We'll show you some more in a minute. Okay, so there's the first one tied. Now we're going to do the same thing with the second suture, but you can see how we've tried not to over tension, just to give enough compression to hold that in position to heal.